who isn't a super regular discussant, can join us if you'd like. What do you think? No worries. Always welcome to attend and participate in any way that people like. All right. Okay, let's Hamza. Hi, Hamza. Thanks for volunteering. That would be awesome. Abdulaziz, hi back at you. I don't know if you just joined and you're saying hi, or it was the hi in response to the call for discussants. But either way, welcome. Hamza, of course you can do it either way, but if you would much appreciate co-discussant, okay, that would be perfect. Abdulaziz, please and thank you. Why don't y'all unmute and say hello, introduce yourselves to those who may not remember you, and then we'll go to Anne-Marie.
Hello, my name is Dr. Khan. I'm here at Baptist Southeast Hospital as an observer. So I'm actually a graduate of 2019 from Islamabad in Shifa College of Medicine, and just gave my step 1 earlier this year, and currently applying for this year's match, but still have to step 2 coming up. So that's, yeah, I have the step 2 coming up maybe in a month. I'm familiar with the format of the CP solvers. I've been on some of the VMR sessions, and really appreciate what you guys are doing. I'd really like to learn as well from this experience. I don't know if I can do justice on the first go, but I'm eager to learn.
Thank you so much for taking the leap. I promise you will learn a lot in this experience, and I promise you will get at least one additional question right on step 2 CK because of it.
Yeah.
Abdulaziz. Abdulaziz, we can't hear you if you're speaking. I think you're unmuted, but I can't hear you. Anybody else? Can anyone else hear him?
Hello.
Hey.
My name is Abdulaziz. Sorry, I have bad connection in my area. My name is Abdulaziz. I am from Somalia. I am graduate from Sudan and started my internal medicine rotation in Sudan. Nice to meet you.
Abdulaziz, we've discussed together before, is that right?
Yeah, this is my second time.
Okay, yes. Thank you for joining again. I remember, yeah, it was a few months ago, I think. Great.
Yeah.
And Anne-Marie, you want to just say hello and take us away?
Hey everyone, I hope everyone's having a great Wednesday. I am a hospitalist at UNC and help with VMR. So I've got a case saw a few years ago. It was a human diagnosis case, but hopefully no one remembers it. So this is a case of a 32-year-old male presenting with an abdominal mass. So the symptoms started 1 month prior to presentation with bloating, nausea, cramping with eating, and constipation with occasional watery stools. The patient has lost 20 pounds of weight in the last month. He feels very weak and has noticed an enlarging abdominal mass. Review of systems. Sorry, I'll just pause a moment. Was negative for weight loss, night sweats, shortness of breath, cough, hemoptysis, hematochezia, dysuria, hematuria, rashes, joint pains, or muscle aches. And then I'll pause right there.
Thanks, Anne Marie. Hamza, if you don't mind, why don't you just start us off by sharing your thoughts about this young man with abdominal mass, as well as a month of kind of nausea, vomiting, constipation, diarrhea, and weight loss.
Well, just to be very honest with you, so I think that the age group is really important. It's a young patient presenting with a mass, and there's no systemic symptoms really. It's very focal in nature. The cramping and the nausea and vomiting, that gives me maybe my differentials. I can't really say what exactly. I can't really focus on any differentials right now, but I need more information further on from here on out. If Abdul Aziz, can you enlighten us all with what you think? I think I need more information. Yeah.
So I think this patient have abdominal mass and vomiting and nausea for 1 month. And weight loss is like a chronic illness. So I think it is a part of malignancy or a part of chronic infection like granuloma. So and this patient have chronic vomiting and nausea. There is a right of question. There's some sort of obstruction, gastric obstruction that from the mass or from restriction that lead to vomiting and weight loss. So abdominal mass. So I think it's a part of malignancy, granuloma. So I don't know what should go. So I need more information.
Thank you, guys. I think you're I'm thinking kind of the same way, where it's there's only so many things that grow, right, that can present with masses, and the way that at least it's sort of framed, where the chief symptom or is an abdominal mass, it sounds like it's a big one if the patient is noticing, right, if that's the kind of the chief complaint. And of course, neoplasm is at the top of the list because of that, as well as the weight loss, which y'all pointed out. And then the question is, is it a benign growth or is it a malignant growth? Some of his other symptoms, as well as the weight loss, might suggest that it's malignant. And then the question is what type of cancer is it? Depending on some of the details of how quickly it's grown and some of the other symptoms, there may be a suggestion that it's a lymphoma, hematologic malignancy, versus a solid tumor, an adenocarcinoma, a sarcoma. But ultimately, that's going to be determined histologically, right? So when you hear like big mass and weight loss, it's probably something in the realm of neoplastic diseases. Other things that Abdulaziz, you were mentioning that can present with a mass, certainly infections, and a lot of different infections can present with mass-like lesions. Usually, it's a subset of those that can grow slowly enough and not cause enough problems in other ways for it to present with a main symptom of a big mass, of a swelling, right? Usually if you have an abscess somewhere, there's only so much it's going to grow and create pressure before someone becomes, septic and presents sooner, right? But other types of infections can more typically present with like mass-like lesions, mycobacterial and fungal disorders, right? Actinomycosis. There's some infections that can present with sort of a larger oma, so to speak. I like the use of the word granuloma, and it reminds us that a lot of granulomas, they can be infectious, but they can also be sort of immune-mediated disorders, right? And those can also present with mass-like lesions, whether that's IgG4 related disease or sometimes sarcoid, just involving lymphadenopathy, for example, et cetera. But again, depending on the size of this thing, that would be a lot less likely. And then the final point that I want to commend sort of Abdulaziz for sort of holding on to was that, these prominent GI symptoms, the nausea, the cramping, constipation alternating with diarrhea, does potentially invoke that there's GI kind of luminal obstruction. And you can think of that as either being intrinsic or extrinsic. The other possibility for this prominence of GI symptoms is that the mass is neurohormonally active and is not physically messing with the flow of stuff through the GI tract, but is having endocrine sort of biochemical effects causing dysmotility, hypermotility, hypersecretion, et cetera. And you can think of that in the category of neuroendocrine tumors, which can happen in the pancreas, but can also arise from other parts of the GI tract, as well as outside of the GI tract. So with that, I think we have a decent sort of 10,000 foot view approach, and we can maybe get the next aliquot and see what we think.
Okay, so on further history, the patient returned from a trip to North Africa, where he was visiting family for 3 months, 1 week prior to admission. Noticed the mass towards the end of the trip. No unusual exposures or insect bites that he noticed, although was around cattle and sheep, and did not take malaria prophylaxis or other prophylaxis prior to the trip. No past medical history or surgeries, and takes no medications or supplements. Has not been in access with medical care kind of most of his life. No alcohol, tobacco, or drug use, and then no recent sexual activity. And then is not sure about whether or not he received his childhood vaccinations. Do you want to discuss from here or get the physical exam?
No, just move on to the physical exam. Yeah. Abdulaziz, are you good with that, or do you want to bring up a point?
Yeah, I think when someone have travel history of Africa, the
Mhm.
top differential I think the tropical infection or tropical infection like brucellosis, tuberculosis, and so I write that I think this patient have more infection, tropical infection. So this is my big idea now. So I like to find what have the examination of this patient have hepatomegaly, splenomegaly, where is where is the mass? Is it right iliac fossa mass or is right upper quadrant mass?
Yeah.
So I think I like to see the examination.
Thanks, Abdulaziz. I agree. Hamza, does the contact with cattle or sheep, does that create any sort of associations for you?
Uh, Most likely, if we're thinking along the lines of cattle exposure, then in my mind, that's maybe has to do with uh, uh, Coxiella, but again, it has the location. So we can, the problem is that the location, the travel exposure of Africa, that it's not really associated with that. So if you have something, if you have exposure to Coxiella burnetii, you can maybe think of possible appendicitis, ileus, because it does have associations with those two conditions.
Awesome. So you're absolutely right. So Coxiella, the spores can actually travel a long distance away from their origin with from the cattle, and you can be sort of infected even if you didn't go near cattle. Yeah, it's harder to imagine that Q fever usually doesn't present with mask-like lesions as well as as much as it does with more systemic illness, potentially pneumonia. Now it does make you think, as well as sort of the other organism that Abdulaziz thought of, which is brucellosis, which can also be contracted from either ingesting unpasteurized or not fully cooked livestock products, as well as from direct contact from the livestock. Brucella, I guess, more commonly presents with mass-like lesions, but still not typically enough for it to be a chief complaint of abdominal mass, unless the abdominal mass is actually organomegaly, right? If the abdominal mass is actually a big liver or a big spleen, a lot of these zoonotic infections can cause exactly that. Organomegaly, and could fit with this presentation. What about so sheep, North Africa? What about echinococcus? What do y'all know about echinococcosis?
Well, echinococcus is fairly more common to these parts, Southeast Asian parts of Southeast Asia. Sheepdog feces are where you can get the as far as I remember, oocysts can actually be present inside the sheepdog feces, and that can cause hydrated cyst disease. And I've actually written a case report on a patient with cysts in the liver, the gut, the brain, the bone, and disseminated hydrated cyst disease could be a possibility, but I didn't think to mention that because it's such a disseminated case would be very rare to find. But yeah, certainly something. Thank you for bringing that up. Maybe we should be thinking about that. Maybe we shouldn't completely rule that out as well. Abdulaziz, do you want to add anything to this?
You know, don't have anything to add.
Thanks, Hamza. And yeah, so, echinococcosis can be disseminated as you've described, and thank you for sharing that great kind of experience learning about it. It can also just be in the liver, right? And it can cause, some mass effect where the enlargement could be appreciated. And then the other way it could interact with the other symptoms is that, we talked about how some of these GI symptoms could be physically obstructive or kind of chemically mediated, right? Biochemically mediated. And one way that echinococcosis could cause quote unquote biochemically mediated diarrhea, for example, is that if there is intermittent exposure, systemic exposure to that allergen and intermittent mast cell activation, sort of and systemic reaction, a big manifestation of anytime you're exposed to sort of your IgE, IL-4, IL-5 kind of mast cell branch of your immune system, the GI tract, right? The effect of histamine on the GI tract, like abdominal cramping, bloating, diarrhea, vomiting, can be the manifestation, just like you see in anaphylaxis, for example, right? So that's one way that things could be tied together. Okay, so let's. Anne Marie, and by the way, feel free to pace this however you feel with the aliquots. But let's move forward. Yeah.
Okay, vital signs showed a temperature of 36.8 degrees Celsius, a heart rate of 105, a respiratory rate of 16, blood pressure of 140/92, and then normal oxygen saturation on ambient air. Generally, he appeared cachectic and chronically ill, but no acute distress. On ENT exam, there was no cervical lymphadenopathy. There were a few hyperpigmented black pinpoint lesions in the anterior tongue. Cardiovascular was tachycardic, but regular rhythm without murmurs. Lungs were clear to auscultation and with normal work of breathing. On abdominal exam, there was a large hard mass encompassing most of the abdomen, with some discomfort to palpation and abdominal distension, but there was no rebound or guarding and no fluid wave felt, no femoral lymphadenopathy. And then on the extremity exam, there was no edema, no rashes, and then peripheral pulses were present. As far as the labs, the WBC was 4.3 or 4.7 with an ANC of 3.2 and absolute lymphocyte count of 0.9, and then normal basophils, eosinophilias, and other cell lines. The hemoglobin was 9.8 with an MCV of 75, and the platelets were 535. There was no baseline labs for comparison. The sodium was 136. The potassium was 4.3. The chloride was 97. The bicarbonate was 31. The BUN was 6. And the creatinine was 0.5. The glucose was 90. The calcium was 9.2. The albumin was 3.2. And then magnesium level was normal. And then I will leave it there for right now and then give you some more labs.
Excellent. Yeah, thank you. And okay, so just to emphasize, so other concerning findings that just point us out into that malignancy, towards that malignancy suspicion is the cachexia. And then what I think really stands out in this is a very peculiar finding on the anterior tongue, the hyperpigmented plaques that I'm now thinking more in terms of, could it be possibly maybe Kaposi, or could it be, could this point out towards Peutz-Jeghers, because Peutz-Jeghers syndrome is definitely associated with hamartomatous plaques, hamartomatous polyps in the GI tract. So could that be causing a possible obstruction? And apart from this, there's definitely some iron deficiency sort of picture going on as far as I think with the hemoglobin decreased and the MCV below normal. I'm suspecting iron deficiency, possible GI bleed, maybe a growth that's also bleeding. This is where this is along the lines that I'm now highly thinking along. What about you, Abdulaziz? Do you want to add your input into this?
I think this patient, they have weight loss from the cachexia. So yeah, it's just going to chronic illness like malignancy and chronic infection. So really, hyperpigmented point to anterior tongue, a large heart. When you have a large heart mass, so toward to the malignancy, so the malignancy like have the heart mass. But, really, it's just I don't know where I go. So really, I don't have a good idea really at this point. From the lab, I see the patient have low hemoglobin, a low MCV, go with iron deficiency anemia, and have high platelets that is going chronic inflammatory process. So sometimes when you have low anemia or chronic infection, you have high platelets.
Awesome, y'all. Great discussion on this new aliquot of information. I love the possible connection between these things we're seeing in the mucosa. I was just Google imaging Peutz-Jeghers, and I thought it was more the lips that.
So I have question why the question about hyperpigmented. Yeah, it's a good idea.
Sorry, Abdulaziz, I think you cut off. Could you repeat what you said? I'm just gonna wait.
Abdulaziz might be having some connection troubles, but hopefully he can rejoin us soon. I think the other thing that you were pointing out, Hamza, the microcytic anemia that may be iron deficiency, could also be inflammation. So we should confirm with the ferritin and some iron studies, but it may further localize to the actual GI lumen, and the mechanism of occult chronic blood loss. One thing that kind of stands out to me in the labs is the potassium of 4.3. And somebody who's just been more malnutritioned and has also been vomiting and having diarrhea and stuff. It's a little surprising that it's not higher. There's also some likely metabolic alkalosis with elevated bicarbonate. you know, with diarrhea, you would expect a non-GAP metabolic acidosis, right? With prominent vomiting, you may see some acid losses and metabolic alkalosis. But we might also think about this patient's adrenal function, given that biochemical profile of relative hyperkalemia and metabolic alkalosis could be consistent with that, as well as some of the you know, both non-specific GI symptoms, as well as, you know, some abdominal mass that may be involving the adrenals and causing insufficiency. So I think we really are just itching at this point for some imaging, though, to better kind of characterize the location, anatomy, and possible origin of that mass, as well as, of course, the LFTs. So let's do that.
Okay, so to finish up the liver enzymes, the total protein was 7.7. The total bilirubin was 0.5. The AST was 76, and the ALT was 43. The alkaline phosphatase was 199. The thick and thin smear actually came back positive for Plasmodium falciparum with less than 1% burden of the RBCs. The CT of the abdomen and pelvis showed a large, predominantly low-density mass with more peripheral solid areas measuring 11.7 times 19.7 times 20.3 with surrounding mesenteric lymph nodes. The origin of the mass was difficult to identify. CT of the chest showed no kind of acute changes, and then HIV was negative, and quant gold test actually, quant gold was negative as well. Or actually, sorry, quant gold was positive.
Okay, a lot going on in this test. Hamza, what do you know about sort of, can malaria do all this? And then what do you make of the positive quantiferon? And real quick, sorry, before you answer, Anne-Marie, is there a comment on the size of the liver and the spleen?
The liver and the spleen were not enlarged.
Okay, thanks. Go ahead, Hamza.
I don't believe that I'm familiar with an abdominal mass due to malarial disease. I think we should be, the quant gold coming back positive definitely builds a more, takes us towards more of a familiar TB sort of approach. I'm not sure. If Abdulaziz, can you add to this? I don't really think I have much to say about this.
Really, I don't think malaria can cause malaria. The malaria can cause everything. I don't see cases happening because it's faster. But if you want to give to this, so I think it's patients go to abdominal tuberculosis. So what the differential is abdominal TB in this case, I think they need to take a biopsy to compare any granuloma and necrosis for this case. So the next step is take a real biopsy from this patient. I think my differential is abdominal tuberculosis.
Thanks, Abdulaziz. Yeah, no, I agree with both of you. I don't, this might just be a knowledge gap, but I don't think of malaria. I can't think of a mechanism by which it would cause such a giant, you know, mass. One thing I was asking about the splenomegaly is you can have accessory spleens. You can have tiny little splenules kind of separate from the main spleen. And I was imagining that maybe, you know, you could have significant enlargement of some of those splenules, and in the setting of malaria and potentially present this way. But if there's also a normal spleen and it's not enlarged, as well as just the way it's described with, you know, central hypodensity and everything, you can have, I mean, some degree of autoinfarction in massive splenomegaly, but doesn't quite make a good story. And then same with, like, I don't know, like tuberculoma, this giant tuberculoma, I think it's possible, but we should also keep in mind that both in the case of malaria and in the case of, you know, what the positive quantiferon, like this person could have multiple chronic things, and the current presentation has nothing to do with those things, right? This could just be latent TB. It's a positive quantiferon, like, you know, so many people are exposed, but this may not actually be active tuberculosis, the present syndrome we're dealing with. Same with the malaria. So I think ultimately we do need, you know, sampling of this mass, of course. Now, one thing that is sort of conspicuous, Anne-Marie, lymphocytes were 0.9, like 900 was the absolute lymphocyte count?
Yeah, that's correct.
Okay. So one thing that we definitely need to know is this patient's HIV status, which could both, you know,
HIV was negative.
Negative, you mentioned. Okay, sorry about that. Okay, great. Thank you.
I think
yeah.
that's really
and then
advice. I'm sorry to cut you off. Sorry, keep going.
No, go ahead, please.
I'm just saying. I think that was really helpful from your part to know, because I do, now that you say that, I do believe that having that in mind, thinking that we should be more focused still about the overall picture, instead of using the new upcoming caveats of information that Anne just laid out in front of us. I think thinking along not letting go of the malignancy viewpoint is still very important, because there's still this patient who's very young, is presented with a chronic mass and chronic symptoms, and these are very, you know, they're systemic. They are systemic systems. Now, the weight loss and the cachexia, and also the fact that this is a really large mass, and I think maybe still entertaining the hamartomatous polyp to malignant transformation. Could that be, I just wanted to ask, could that be on our, what's it called? Should we think along those lines still?
I think something that's a little bit unusual here is the size of the mass and maybe how quickly it grew. You know, the patient's only been symptomatic for a month. Right. It's possible that before a month ago, he had a 15 centimeter mass that was not symptomatic. And then it reached a critical point of becoming, you know, 20 by 20. And then he started feeling, right? Then he became symptomatic, noticed that his belly was big. Given that he's clearly a very thin person, 20 by 20, like this is the size of the mass, right? It's the size of my head. So I think he probably would have noticed it at an earlier stage. So presumably this is a very rapidly growing mass that got to 20 centimeters, potentially on the order of a couple of months. And the natural history of adenocarcinomas, certainly of colorectal, you know, origin adenocarcinomas, is not to grow that quickly. They grow over, you know, much more slowly, initially in their pre-malignant stage, right? When they're just polyps, benign sort of tumors, they grow over years. And then certainly the tumor biology can evolve and you can have an acceleration of the pattern, but not on this time course. The other thing is that, you know, colonic adenocarcinomas and other tumors arise usually from the mucosa, right? Most GI tumors, they come from the mucosa, from the inside. There's some, you know, wall tumors, you know, gist and other things that can be, you know, stromal and not from the actual cells on the lumen, but most of them arise from the lumen. What that means is before you get to the point of being 20 centimeters big, usually you've caused complete obstruction of the lumen, and you have presented with like complete, food intolerance, fecal emesis, like, so it's very unlikely that this is the origin of this is the GI tract, in my opinion. And then given also the geography and everything, I think what shoots up towards the top is lymphoma, and specifically the fastest growing lymphoma, which is Burkitt's, which certainly can present in the, in the abdominal cavity. And, this may be, there's this mass and lymphadenopathy, right? But this could be a giant necrotic lymph node and then other involved lymph nodes, if this is a lymphoma. And that would also potentially explain that borderline elevated potassium. There may be some tumor lysis that is happening. I'd also be curious to see this patient's uric acid and phosphorus and LDH, but ultimately, I think we just need, without any delay, a tissue diagnosis, I think at this point, in order to know what this is and how to treat it.
Okay, awesome. Well, LDH was 2,434. Other TLS labs were not like remarkable for no signs of tumor lysis syndrome. I don't have a ferritin, but I'm thinking it was like in like the kind of like mid 100s, around like 400-ish range, if I remember correctly. And then it was actually, did ultimately get a biopsy of the lesion, but there was actually a physical exam maneuver that kind of raised the ultimate diagnosis to highest on the differential. So I didn't know.
Yeah, let's pause there and see if we can guess what that key physical exam is. Hamza, any ideas?
No, sorry.
How about you, Abdulaziz? And no need to be sorry, by the way, Hamza.
I don't
you've done great.
I don't have any idea what that kind of maneuver. I don't know really.
So let's see if we can. So the LDH, what does an LDH tell us? It tells us there's essentially a rapid sort of turnover or lysis of cells. Those cells could be malignant cells that are outgrowing their blood supply, right? Those cells can be our own endogenous cells, right? The LDH is very elevated in acute liver injury. It can be elevated in myocardial infarction, in rhabdomyolysis, et cetera. And it can also come from from outside, so cells lysing, like infectious cells lysing. But as far as tumors go, as far as the category of cancer goes, we most associate it with lymphomas, right? Or with leukemias. And then one other type of cancer that it's considered considered a tumor marker for another type of cancer, along with like, sometimes you check, these specialists might check an HCG with an LDH. Bells ringing, yes, no, maybe. So I think the exam here that was missing and that should be done iteratively is a good testicular exam. That could be, the source of a germ cell tumor or choriocarcinoma that, am I saying that right? Choriocarcinoma? That can then metastasize into the abdominal lymph nodes and disseminate and grow rapidly. So in the interest of time, Anne-Marie, tell us what happened to this case, and then we'll ask Franco to summarize the teaching points.
Yeah, so the testicular exam actually showed an undescended right testicle. So the patient had denied testicular masses, but due to the undescended right testicle, that had developed into a tumor. Biopsy of the abdominal mass showed a germ cell carcinoma of yolk cell origin, and was treated with BAP therapy. Did get an AFP was checked and was 26,000, and a beta HCG was less than 5. So I just thought this was an interesting case because it points to how just thinking about kind of, it's easy to get distracted with recent travel and everything, but also about thinking about how like access to medical care can sometimes like predispose to things that could have a sequelae kind of down the road that you might not think about at the time.
Yeah,
Wow.
I think this is a very good demonstration of just how it was a roller coaster right from the start. We were thinking along so many lines. I think infectious causes, the malignant causes, all these things. It just demonstrates how important it is to have an approach, a very well thought out approach to your physical exam findings and history taking to be able to rule out and order up lab work accordingly. And yeah, Abdulaziz, how do you feel about this experience?
Yeah, I think it really is a very interesting case, and every time I discuss with VMR, I learn so much. So interested, very interested case. I like it so much, and that it means that how important the simple examination will tell you about the diagnosis. So it's nice.
Wonderful. Both of you did an excellent job, and thank you for volunteering. Hope you will again. Take us away with the summary, Franco. What did we learn from this case?
Oh, this is an amazing case, and I have to credit Kushal that on the chat he said that there was going to be a twist at the end, so we saw the twist at the end actually. So for the teaching points, regarding the weight loss, always look for if it is a pathological one or if it is a non pathological one. One thing that it's always kind of repetitive here in CP Solvers is that if you see your patient and you want to congratulate him or her and give you a high five, it's kind of more non-pathological weight loss. If you see the patient that is some cachexic and you don't want to congratulate him or her due to the weight loss, is probably a pathological one. So look for that kind of pearl. Regarding an abdominal mass, always look for the growth speed, the size, where it's located, and what symptoms are associated with the mass. The weight loss, if there is some weight loss, if there's systemic symptoms like fever, so you can distinguish if there is going to be a malignant or a benign one. Also, be aware of the mimickers. Some abscess parasites can present as masses. Lymphadenopathy due to non-specific inflammation, especially with autoimmune disorders, organomegaly. Also look for exposures, travel, occupational, and pets owing that can be related to certain kind of mimickers of masses. When you try to localize an abdominal mass, the first thing that can come up is the GI tract. So sometimes the GI tract can be associated with anemia, the most common being a chronic GI loss, but also be aware that some kind of masses can have anemia of chronic disease. Regarding one of the most common ones being the colonic adenocarcinomas, usually take years to develop. Be aware of the polyp to the adenocarcinoma natural history. So that can be a point to look for the kind of the speed of the growth, the speed rate. Large solid tumors can have tumor lysis syndrome, especially if there is a high tumor burden. So be aware of that. And always, if there is a mass and there is something that is not quite in meeting that is something like really available, you need to do that tissue is the issue. So always biopsy them and you can have some surprises over there.
Thanks so much, Franco. That was awesome. Thanks again, everybody who participated and everyone who called in to learn. I hope y'all have a great week and see you next time.
Goodbye. Thank you.
Bye, everyone.